All right, I was reading the AGA guidelines on Barrett's esophagus today. The AGA is one of our GI societies. And so I thought I'd talk a little bit about Barrett's esophagus today. What is Barrett's? Where does it come from? What's the implications of having Barrett's esophagus? Cutting to the chase, Barrett's comes from acid reflux, and it can lead to cancer of the esophagus. It's the proximate cause of cancer of the esophagus. So it's a serious, serious condition. We take it seriously. But let me start with a little story first. So the story is about Kathleen and Chuck. Kathleen was an endoscopy nurse who worked in our office. Great nurse, very meticulous. I loved working with her. And she had a husband named Chuck. And Kathleen and Chuck were going to retire in northern Minnesota. He was building a house in the woods for the two of them. Unfortunately, Chuck had Barrett's esophagus. And Chuck's Barrett's esophagus progressed to the point where he had high-grade dysplasia. Dysplasia means bad cells, dangerous cells. And Barrett's can go through stages of baseline Barrett's, metaplasia we call that, and then low-grade dysplasia, high-grade dysplasia, cancer. Chuck had high-grade dysplasia, so he was at high risk to move on to cancer. And this is about 25 years ago. And in those years, what happened was we removed the esophagus to treat high-grade dysplasia. Brutal procedure, just brutal procedure. Remove the entire esophagus. We pull the stomach up, sew it into the region of the neck. Poor Chuck, man, he struggled. He got through it, he survived, but he was never the same. And I saw this, as a young gastroenterologist then, and I had been thinking about this, Barrett's high-grade dysplasia and the brutality of the surgery, and I thought there's got to be a better way. So I actually invented a better treatment for Barrett's, radiofrequency ablation. And I teamed up with a dermatologist and a electrical engineer named Roger Stern. And the three of us came up with this radiofrequency ablation procedure. It's now called the Halo procedure, or Barrx, B-A-R-R-X was the name of the company that we founded. And the Halo procedure is radiofrequency ablation. It's these thinly spaced RF electrodes, and we just burn off the Barrett's. And Barrett's is very thin layered. The tissue of Barrett's is very thin layer. It's only about 500 microns. So to do this required exquisite precision. Nobody thought we could do it, but we did it, and it has now become the standard of care for Barrett's esophagus, for the higher grades of Barrett's esophagus, which is fantastic. Unfortunately for Chuck, we came out a couple months after his surgery. It was such a shame. But anyways, okay, so what is Barrett's esophagus? So Barrett's esophagus is a certain type of cell change in the lining of the esophagus. So the esophagus is kind of a dumb organ. It doesn't secrete, it doesn't absorb, it just pushes food through. So the cells that line the esophagus when we're healthy are the same kind of cells that line our skin. They're short, flat, squamous cells, we call them. And if you get acid reflux, after many years of having acid and bile come up into your esophagus, it's usually a lot of acid and bile over many years, you can get a change in the lining of the cells from these short cells to taller, columnar-lined, primitive intestinalized cells. And we call that change Barrett's esophagus. It's named after a fellow named Roy Barrett, an Australian surgeon who first described it. And when you go from those short, flat cells to the taller cells, the intestinalized taller cells, that's a big problem because those cells can then lead to cancer. So Barrett's esophagus leads to cancer. So reflux leads to Barrett's, Barrett's leads to cancer. Without Barrett's, you typically don't get cancer of the esophagus, even if you have lifelong acid reflux. So it's Barrett's that's really important. And Barrett's, if you have low-level Barrett's, typically you're not ablated. If you have low-grade dysplasia or high-grade dysplasia, these cellular changes in the lining of the esophagus, then we typically offer you ablation. And I'm happy to say that it's very rare now to have somebody's esophagus taken out for Barrett's esophagus. So that's Barrett's. If you have Barrett's and you have lower levels of Barrett's, the metaplastic kind, it's still precancerous. You would typically go into a surveillance program, although I personally offer all my patients ablation, but you go into a surveillance program that's per the AG guidelines that I just read today. It's 3 to 5 years. I personally think that's too long an interval for people with Barrett's esophagus. Endoscopy is a very low risk procedure, almost no risk to it. And I would survey patients much more frequently than 3 to 5 years, but that's just me. The field says 3 to 5 years. I kind of disagree with that. The problem with the surveillance guidelines, all surveillance guidelines, is unfortunately there's no data to really back up the practice or the interval. So it's kind of a made-up interval. It's been the standard over decades, and so we do it, but I personally am not that pleased with it. I would survey patients a lot more frequently. I would defy you to find a gastroenterologist, any gastroenterologist with any length of Barrett's esophagus who would wait 3 to 5 years, every 3 to 5 years to be endoscoped. I don't think that would happen. I think those gastroenterologists would be endoscoped a lot more frequently. But that's me, and I didn't write the guidelines, and the people that write the guidelines are my friends, and I don't want to piss them off. So I'm just giving you my opinion. So that's my little primer on Barrett's esophagus. As always, leave any questions and comments that you want. I'd be happy to get to as many as I can, and we'll tackle something else in a day or so. All right, you take care.